Imagine a patient is rushed to the hospital with heart failure, and the doctors, they check all the usual suspects.
Right. They look at the plumbing.
Exactly. There are 0 blocked arteries.
Yeah.
The valves are perfectly fine, just opening and closing with absolute precision.
Yeah.
Blood pressure is completely normal. The plumbing is completely clean. So if everything is mechanically perfect, why is this patient's heart failing?
Well, when you strip away all those comforting mechanical explanations that cardiologists usually rely on, when the pipes and the pressure are totally fine, you are forced to look at the material of the pump itself.
The actual muscle.
Right. And clinically, that is a diagnosis of exclusion. You can only arrive at the specific diagnosis after methodically proving it's not, coronary artery disease or chronic hypertension.
Or like a leaky valve or a congenital defect.
Exactly. Once you eliminate all those external forces that break the heart, you're left with the reality that the muscle tissue itself is the primary problem.
Okay, let's unpack this, because this exact medical mystery is the mission of our deep dive today. We are exploring cardiomyopathies.
Diseases where the myocardium, the heart muscle, is the disease.
Right. And we've got a really fascinating roadmap for you today. We're going to look at the history of how doctors actually figure this out and the 4 primary ways the heart muscle can physically break down.
Which gets incredibly complex.
Oh, absolutely. Plus, there's this wild transatlantic debate on how to even classify these diseases. And finally, the mind-bending reality of broken heart syndrome.
Yeah, to really grasp this, it requires a fundamental shift in how you visualize the cardiovascular system. We have to stop looking at the heart merely as this mechanical pump attached to pipes.
Right, it's not just a machine.
No, it's a highly vulnerable, dynamically changing tissue operating at the cellular level.
So let's rewind to the 1950s to see how that shift started. I was reading through the sources, and before this era, doctors were essentially operating in the dark. Right?
Oh, completely in the dark.
If a patient had unexplained heart failure, it just got lumped into this vague medical wastebasket called myocarditis or myocardosis.
Yeah, they just lacked the diagnostic vocabulary. And the imaging tools, honestly. Cardiologists back then were deeply baffled by these cases involving young people.
Which is terrifying.
It really is. You'd have elite athletes or mothers immediately postpartum who would just abruptly go into heart failure or suffer sudden cardiac death without any of the usual explanations.
And because the dogma was so focused on plumbing, they didn't know what to do with a purely muscular failure.
Right.
It's the classic mechanic analogy. You take your car to the shop because it won't run. The mechanic pops the hood, checks the spark plugs, checks the fuel lines.
And if those look pristine, they just throw their hands up.
Exactly. It took someone stepping back to say, well, wait, what if the engine block itself is forged from faulty metal?
Yeah.
And that conceptual leap came from British cardiologist Wallace Brigden.
Right, in 1957. Brigden published a pair of landmark papers in The Lancet where he finally gave a name to this gap in the literature. He coined the term cardiomyopathy to isolate these heart muscle diseases that just could not be blamed on the usual suspects.
Then once he carved out that territory, the race was on to figure out what was actually happening to the muscle fibers. But what I found really jarring in the sources was the immediate follow-up to Brigden's work.
You're talking about Donald Tier?
Yeah, just a year later, in 1958, Tier published a paper detailing what we now call hypertrophic cardiomyopathy. But Tier wasn't scanning living patients.
No, he's a pathologist.
Right. He was looking at the hearts of 8 young people who had died suddenly. And he discovered this asymmetrical hypertrophy, this massive thickening of the ventricular septum. But my question is, why did it take an autopsy to figure this out?
Well, you have to remember the era.
Couldn't they see a vastly enlarged heart muscle in a living patient?
In 1958, clinical echocardiography, using ultrasound to watch a beating heart in real time, was in its absolute infancy. It certainly wasn't widely available.
Oh, right. Okay.
They could see an enlarged silhouette on a chest x-ray. But an x-ray can't tell you if the heart is enlarged because it's dilated and thin or because the muscle wall is like an inch thick.
It's just a shadow.
Exactly. So Tier's postmortem exams were really the only way to confirm that the tissue itself was growing in this bizarre asymmetrical pattern.
Wow. So once Brigden and Tier proved the muscle itself was the culprit, how did the medical world categorize these structural failures? What exactly is happening to the muscle?
To understand that, you have to look at the three fundamental jobs the heart muscle simply has to do.
Okay, what are they?
First, it has to contract with enough force to push blood out. That's systolic function. Second, it has to relax completely and quickly to refill. That's diastolic function.
Right.
And third, it has to conduct electrical signals in a coordinated way. The four classic subtypes of cardiomyopathy map directly onto the failures of those three jobs.
So let's start with the failure to contract. That's dilated cardiomyopathy, or DCM. Mechanically, the source used this great analogy of a rubber balloon that's been overinflated and stretched out so many times that it completely loses its snap.
That's a perfect way to visualize it. The ventricular chamber, usually the left ventricle balloons outward as the muscle walls thin and stretch out.
So it holds a lot of volume, but it can't spring back to push anything out.
Exactly. At the cellular level, the contractile units are stretched way beyond their optimal length for generating force. So the ejection fraction just plummets.
Ejection fraction being the amount of blood pumped per beat, right?
Right. A healthy heart pushes out maybe 55 to 70% of its blood volume per beat. But in DCM, the heart is basically just weakly quivering. It's pushing out maybe 20 or 30% or even lower.
But DCM isn't just one disease, is it?
No, not at all. It's a shared end state. You can get there through genetics, but it's heavily driven by environmental toxins.
Like alcohol, right?
Alcohol, yes. And also certain drugs like anthracycline chemotherapy. Yeah, anthracyclines are highly effective against cancer, but they can be notoriously cardiotoxic. They physically damage the DNA of the heart muscle cells, leading to cell death. And then that tissue is replaced with fibrous scar tissue, which causes the walls to thin and dilate.
And then there's peripartum cardiomyopathy, which is just wild. It strikes late in pregnancy or right after delivery.
Yes, often in women with zero cardiac history.
And the epidemiological variance in the sources is staggering. In the U.S., it's about 1 in 1,000 to 4,000 births. But it's vastly more common in Nigeria and Haiti.
Right, which points to this incredibly complex interplay of genetics and hormonal changes during pregnancy.
How so?
Well, there's evidence regarding how the hormone prolactin is cleaved into a fragment that is uniquely toxic to blood vessels in the heart. Combine that with potential nutritional or systemic stressors, and the muscle just dilates and fails.
So DCM is the failure to contract. The second subtype, hypertrophic cardiomyopathy, or HCM, is fundamentally a geometric problem.
Yes, a geometric and cellular failure.
The interventricular septum, that wall between the chambers, thickens dramatically from a normal, 8 to 11 millimeters up to 20 or 30 plus millimeter.
Right, and this is a genetic disease of the sarcomere, the actual contractile machinery of the cell. It commonly involves genes like MY87 and MYBPC3.
So it's a genetic blueprint issue.
Exactly. And because the proteins are defective, the cellular machinery tries to compensate by building more sarcomeres, but they don't align perfectly.
So it's just chaotic.
Yes, pathologists call it myocyte disarray. Instead of neat, parallel rows of muscle fibers, they run in these tangled, swirling patterns.
That's terrifying. And the sources point out this is autosomal dominant, meaning a 50% chance of inheritance.
Right.
And it affects about 1 in 500 people, which is surprisingly common.
Yeah.
This is the condition that's tragically relevant in sports, right?
Yes, very much so.
Like the sudden death of U.S. college basketball player Hank Gathers in 1990. I mean, that sparked massive public health questions.
Because that thickened, disorganized muscle creates a very volatile electrical environment. When an athlete with HCM pushes their heart rate to the max, that tangled architecture can just short-circuit into a lethal arrhythmia.
Wow. Okay, so moving to the third failure, restrictive cardiomyopathy, or RCM. This is the failure to relax.
Exactly.
If DCM is the overstretched rubber balloon, RCM is like a heavy leather glove. The muscle squeeze is fine, but it's too stiff to refill.
Yes, the diastolic filling is severely impaired. What's fascinating here is what actually causes that stiffness.
Right.
Very often, it's cardiac amyloidosis. This is when misfolded protein fibrils infiltrate the muscle. They deposit themselves in the space between the cells, turning the flexible tissue rigid.
But wasn't amyloidosis long not to be a super rare diagnosis, like a medical zebra?
It was, for decades. But there was a stunning recent discovery using technetium pyrophosphate bone scintigraphy.
Bone scans.
Yeah, when doctors started using this specific nuclear imaging technique, they realized ATTR amyloidosis was hiding in plain sight. It actually accounts for 10 to 15% of elderly patients hospitalized with this specific pattern of heart failure.
Wait, really? 10 to 15%?
Yeah, it wasn't a zebra at all. We just didn't have the right imaging lens to see it before.
That is wild. Okay, so that leaves the fourth primary failure. Arrhythmogenic right ventricular cardiomyopathy, ARVC.
Right.
This one is the electrical failure.
Yes, and mechanically what happens is the normal right ventricle muscle is progressively replaced by fatty and fibrous scar tissue.
Just 10 zones.
Exactly. And because fat and scar tissue cannot conduct electricity, the heart's electrical signal has to detour around them. This creates what we call reentrant loops, which triggers dangerous, rapid arrhythmias.
Okay, so ARVC and HCM are these silent structural time bombs, closely linked to sudden athletic deaths, which leads perfectly into the intense controversy surrounding how we screen for them.
It's a massive debate.
Right, because I was looking at the findings of cardiologist Domenico Corrado in the Veneto region of Italy. From the 1970s through the 2000s, they mandated pre-participation ECG screening for athletes.
And it worked.
Yeah. It massively dropped sudden cardiac death rates because they caught ARVC and HCM early.
Yeah.
So if it works so well in Italy, why doesn't the U.S. do it for every student athlete?
Well, the U.S. establishment has fiercely resisted it for a few reasons. First, the sheer high costs and lack of infrastructure to screen millions of teenagers.
Sure.
But clinically, the massive problem is false positives, heavily driven by the gray zone of the athlete's heart.
Right, because there's a counterintuitive fact here. Elite endurance athletes naturally develop structural heart enlargement, right?
Yes, physiological hypertrophy. Their hearts get bigger to handle the massive output demands of their sport.
But on a scan, it looks confusingly similar to diseased tissue.
Frustratingly similar. So you have this agonizing diagnostic gray zone. Disqualifying a healthy athlete based on a false positive destroys their career.
Yeah.
But clearing a diseased one based on a false negative, that's a fatal mistake.
It's an impossible choice. And speaking of impossible choices, the sources highlight this massive, unresolved transatlantic clash on how to even classify these diseases.
Yes, the AHA versus the ESC.
Medical students are literally taught two conflicting frameworks today, often without being told they are competing.
It's true. So in 2006, the American Heart Association proposed a genotype or etiology-first scheme. They wanted to split cardiomyopathies into primary genetic disorders versus secondary acquired diseases.
Because our genetic understanding had advanced so much.
Exactly. But in 2008, the European Society of Cardiology completely rejected that. They proposed a phenotype-first scheme.
Keeping morphological buckets.
Yeah.
Dilated, hypertrophic, restrictive.
Right, because their argument is highly practical. Doctors in an exam room or an ER need to know what the heart physically looks like before they know its molecular cause. The physical geometry dictates the immediate life-saving treatment.
And you can see how sloppy classification fails when you look at HOCM. Hypertrophic obstructive cardiomyopathy.
Yes, historically, people used HOCM as synonymous with all HCM.
Which is a huge mistake.
A massive mistake. Only a subset of hypertrophic patients actually have the physical obstruction, where the thickened septum bulges and blocks the outflow of blood.
And it's vital to know that because of newer targeted drugs, right?
Exactly, like the myosin inhibitor mavacamten, which was just approved in 2022. Or surgical septal myectomies. Those treatments are designed specifically for that obstructive subgroup. If you give mavacamten to the wrong phenotype, you could precipitate severe heart failure.
Wow. So we've talked about genetics, fatal arrhythmias, and permanent muscle damage. But here is where it gets really interesting.
Okay.
What if I told you some of these terrifying diseases are actually completely reversible?
It's such an important point because it clears up a major misconception. People think cardiomyopathy equals heart failure.
Right, they use them interchangeably.
But heart failure is just a symptom-based syndrome. You can have heart failure from a plumbing issue with a totally healthy muscle.
Okay.
And conversely, you can have a cardiomyopathy without, yet having heart failure.
Makes sense.
And the second misconception is that it's all permanent.
Right, like tachycardia-induced cardiomyopathy.
Yes.
If a patient has a sustained fast heart rhythm, like atrial fibrillation, it literally grinds the muscle down into a dilated state.
It just wears it out.
But counterintuitively, if you fix the heart rate, the muscle can fully recover.
The cells basically hibernate to survive the stress, and once you fix the rhythm, they bounce back.
That is amazing.
Yeah.
But the most mind-blowing exception has to be Takotsubo, broken heart syndrome.
Oh, absolutely.
Yeah.
Discovered by Japanese researchers in the 1990s.
And the trigger isn't a genetic flaw. It's severe emotional or physical stress, like grief, or even a surprise party.
Right. The brain releases this massive surge of stress hormones, catecholamines, which toxify the heart muscle. The left ventricle physically balloons into the shape of a takotsubo.
which is a Japanese octopus trap, right?
Exactly. It has this very distinct narrow neck and wide base.
And mechanically, this mimics a massive heart attack on an ECG, complete with chest pain. But when they check, the arteries are totally clean,
Pristine plumbing.
and most patients just recover within a few weeks. So what does this all mean? The fact that the brain's stress response can literally reshape the heart's architecture.
Well, if we connect this to the bigger picture, cardiomyopathies are not just textbook obscurities.
No, clearly not.
They dictate major sports policies. They drive the fast-growing field of cardio-oncology as we try to manage chemo-induced heart damage.
Right.
They represent a critical maternal health issue, especially in under-resourced systems dealing with peripartum cases. And they remind us that rare diseases like amyloidosis are sometimes just underdiagnosed diseases hiding among the aging population.
They really force us to look closer. Thank you so much for joining this deep dive to our listeners. And I want to leave you with one lingering thought.
Go for it.
If extreme emotional stress, like a surprise party, or profound grief or chemical exposures can temporarily or permanently rewrite the physical shape and cellular organization of our heart muscle, to what extent is the human heart acting as a physical diary of a person's life experiences, traumas, and environments? If our muscle fibers are quite literally shaped by how we live, what might future diagnostic imaging be able to read about our life stories just by looking at the geometry of our hearts?